Professor of Neuropathology at the University of Iowa with a specific focus on neuromuscular pathology. She received her MD and PhD from the University of Kansas School of Medicine, where she examined peripheral nerve innervation of muscle spindles in the setting of diabetic neuropathy in the Department of Anatomy and Cell Biology. She then completed her anatomic pathology residency and neuropathology fellowship at the University of California, San Diego, where she subsequently practiced diagnostic neuropathology, led the neuromuscular pathology service, and assisted in biorepository and biomarker laboratory efforts. Dr. Jones moved back to the Midwest in 2016 to join the neuropathology group at the University of Iowa Carver College of Medicine, where she currently practices clinical neuromuscular and neurosurgical pathology, as well as autopsy forensic neuropathology. She loves teaching trainees of all levels and has received multiple teaching awards. Her research is increasingly focused on neuromuscular diseases with particular interest in inherited muscular dystrophies and myopathies. Dr. Jones is active in the American Association of Neuropathologists and is a member of the College of American Pathologists Neuropathology Committee. I will now turn it over to Dr. Jones.
Thank you so much. I just want to say thank you to Angelica and Maria and all of the organizers and of course the AOE staff too. I really enjoyed all of the sessions that we've had so far, and I'm really happy to be a part of it. And I am a consultant for Audentes, who's now Astellas, but the work is not related to the content of this talk. You've seen the learning objectives already. And so I just want to say my title was High Yield Muscular Dystrophy Pathology because muscular dystrophies in 1 hour, it's pretty much an impossible task. These are two of my favorite reference texts that I use when I am trying to read up more on muscular dystrophies. And as you can see in this practical approach book from Dubowitz and group, there are 5 chapters on muscular dystrophies. And in the big Myology Bible by Andy Engel, there are 12 chapters on muscular dystrophies. So today we're just going to try to talk about some common muscular dystrophies, some tips that I have for diagnoses, pitfalls to hopefully avoid in your practice, and then also some dystrophies that have more unique features. So I saw that one of my mentors, Larry Hansen, is on. This is my homage to Larry. So etymology is very important in studying anything in medicine to understand a little bit more about the history of where these diseases are coming from. So dystrophy, the word itself, comes from the Latin for dys, or bad or faulty, and trophy for nourishment. And it was thought in the mid to late 1800s, when these were initially described in patients, that the muscle wasting was happening due to inadequate or defective nutrition. And for us now, what do we know about muscular dystrophies? Well, we need to use our big umbrella category of myopathies. So myopathies are a disease that is characterized by muscle weakness, whereas the dystrophies are a subset of myopathies that have repeated cycles of myonecrosis and regeneration. So that's going to come up again and again. So when you think of muscular dystrophies, you need to be thinking of necrosis and regeneration. These are genetic, mostly inherited muscle disorders. I say mostly because there are de novo mutations that can occur in the population. It always throws clinicians off when there's no clinical history or no family history, but it can occur for sure. And so when we think about muscular dystrophies, what we really need to be thinking about are the genes that are altered, the proteins that are then subsequently altered that are causing the muscle disease. So this is definitely, muscular dystrophies are a subject that, where molecular pathology is extremely important. And the proteins that are altered in muscular dystrophies can be located in many different myofiber compartments. So this is a nice schematic that's in the Dubowitz book. And this is not inclusive of every muscular dystrophy, but it shows the location of some of the proteins of the more common muscular dystrophies and where they're located in the muscle. So it can be everything from out here in the basal lamina, like collagen 6 out in the basal lamina, coming down into the sarcolemma or the plasma membrane. Proteins that are then attached to the actin cytoskeleton, like dystrophin, and others in the nuclear membrane, Golgi proteins that are involved in glycosylation, and myofibrillar proteins. And so today we're going to focus on some of the more common ones. So dystrophin, we're going to talk about today. We're going to talk about alpha-dystroglycan up here. And then we're also going to come over here and talk about dysferlin. So it's really hard to keep muscular dystrophies straight. There are so many different muscular dystrophies, but there are a couple of ways that you can think about them. And when you get a clinical history on your muscle biopsy, hopefully you get a clinical history when you get your muscle biopsy, then you can use these clinical features to try to help put it into at least somewhat of a category. And so age is very important. Different muscular dystrophies are presenting at different ages, everything ranging from the neonatal period all the way to patients presenting in their 70s and 80s. The pattern of inheritance is something else that's very important. So thinking about, is there a family history? And if so, does it seem like it's X-linked, autosomal recessive, or dominant inheritance? That can help you put it into a category. The muscle groups that are involved. So the pattern of weakness is also very helpful to be thinking about. Are you talking about proximal weakness, distal weakness? Are the facial muscles involved? That can also help. And then, of course, the genes and proteins that are involved. So has genetic testing been done? What genetic alterations are there? Then thinking about, can we test those proteins to see if they are altered and what compartment they're found in? So this is another schematic similar to the one that we saw, coming from a very nice review from Jim Dowling and colleagues on inherited muscle diseases. So again, things happening out here in the plasma, in the basal lamina, happening in the plasma membrane, in the sarcolemma, subsarcolemmal, and then even the sarcomere. So before we talk about the pathology, which is obviously the most important thing, we need to just take a quick moment to talk about nomenclature. The most common and the largest group of muscular dystrophies, sorry, it's not the most common, but it's the largest group, is limb-girdle muscular dystrophies, LGMD. These are proximal muscular dystrophies, and there are so many of them that we can't even list them all here. But the nomenclature used to be the LGMD, and then either 1 or a 2 for dominant or recessive forms, and then a letter afterwards. And once they got to Z, they realized we better do something about this. This is not working out. And so there was a European consensus that came out in 2018, where they've now changed and proposed at least a new nomenclature that now is taking into account a D for dominant, an R for recessive, and then they're numbering them based on when the gene was identified, when it was the timing of when it was identified. And so this will allow us to have many, many, many numbers and keep going. We're not restricted by the alphabet, but also important is that they're really including in the name of the protein, which I think is really important. When you're talking about these, it's very easy to get caught up. What is a D4? I don't know what D4 is. I can't remember. But if you say D4 calpain-3 related, then you remember what the protein is, and then you can remember what the gene is. So talking about the muscular dystrophies based on their proteins is extremely helpful. Okay, so that's what all the dystrophies have to separate them, but what do they all have in common? Well, thankfully, the pathology is all the same in a sense. So dystrophic pathology is going to be common in all of the muscular dystrophies. This may vary a little bit in severity or a lot in severity, but they all are going to have dystrophic pathology. And the ding of dystrophic pathology, the dong, is myonecrosis and regeneration. So that's what you want to be keeping in mind. This is a beautiful illustration that was done by Marion. He was one of the first, if not the first, to actually describe Duchenne muscular dystrophy. And these are some images that he drew, some drawings he did from a Duchenne boy. And we can't talk about myonecrosis and regeneration without mentioning satellite cells. So satellite cells are important to understand the actual process of myonecrosis and regeneration. So Necrosis is going to be a segmental process in a myofiber. It's only going to affect a certain portion of that myofiber, not the entire thing, or the myocyte. And satellite cells are these progenitor cells that sit under the basal lamina here and on top of the sarcolemma, and they have contact with the muscle cell, they have contact with the basal lamina in the extracellular space, and they just sit there on reserve waiting for necrosis to occur. And when necrosis occurs, they start activating and proliferating, and they actually generate a myotube. So once you get myonecrosis, then you get regeneration driven by satellite cells. So we can see this process in muscle biopsies. It starts out very acutely. And so you can see acute coagulative necrosis is going to just be pale pink cells. Then we start to see macrophages that come in, and the macrophages are going to start chewing up the sarcolemmal proteins in the sarcoplasm. And you get more and more macrophages coming in to the point where it actually just looks like a big round circle of macrophages. You can barely tell that it was a myofiber before. And then everything starts to disappear because the macrophages have done their job effectively. And you get to a point where it's almost an empty space that looks like it could have been the size of a myofiber. You may have a few remaining macrophages in here, and then you also have some satellite cells. It's hard to pick them out per se, but the satellite cells are in here doing their job, proliferating and creating a myotube. And regeneration then is going to be characterized. This is a very characteristic image of regeneration where you have a basophilic fiber. You have these large centrally placed nuclei with prominent nucleoli. Those are going to be your regenerating myofibers very classically. These are also regenerating fibers here, you can see. And in paraffin sections, actually in the formalin fixed tissue, you can also see regeneration very nicely. So don't ignore those paraffin sections. Don't just look for inflammation and say next slide. You can actually see necrosis and regeneration very nicely in your paraffin sections as well. And this even is regeneration, which I will prove to you later, but basophilia without even these nice big nuclei that are actively proliferate or actively making proteins, even just that basophilia, that slight tinge of basophilia in these myofibers, that's regeneration as well. So if this is dystrophic pathology, where's the pitfall? Well, the pitfall is that it occurs in highly variable degrees of severity. If you get a biopsy and it looks like this, you feel comfortable saying, okay, this is a dystrophic biopsy. There's fatty replacement, there's fibrous endomesial fibrosis, you have variation in fiber size, you have really big hypertrophic fibers, you have very small rounded atrophic fibers, you have regenerating myofibers, and there's necrosis going on. You have no problem saying, I am suspecting a dystrophy. However, you get this biopsy, it's a little bit different, right? So this one, you see actually in some areas, the myofibers look totally normal, but then you start to pick up, okay, there's some acutely necrotic fibers, there's some grouped regeneration, that will tip you off. I need to start thinking about a muscular dystrophy. This is the hardest one because this one, the only thing you're seeing are some grouped basophilic fibers. There's really no active myonecrosis that you're catching in this biopsy. But you know, if there was regeneration, if there is regeneration, there was necrosis. And so this also is a biopsy from a patient with a muscular dystrophy. This is a Dystroglycanopathy patient with a severe dystrophinopathy. This is a Dysferlinopathy biopsy, and this is a Dysferlinopathy biopsy. So how do I know that those basophilic fibers are regenerating? Well, we can use a stain. So we like to use embryonic myosin heavy chain here. And embryonic myosin heavy chain or neonatal myosin heavy chain are upregulated. They're produced again in fibers that are regenerating. And so you can see that nice grouped expression of embryonic myosin heavy chain confirming that those little basophilic fibers, they actually are regenerating fibers. It's a little bit tricky, but they are. A lot of people also use NCAM or CD56, which also does the same thing. Will highlight your regenerating fibers. And then I've implied this, but I have to say it because this is really, really helpful. Grouped regeneration is going to be your clue that this could be a dystrophy. So just seeing myonecrosis and regeneration in scattered myofibers, your differential is pretty broad and can include immune-mediated necrotizing myopathies. It can include even some forms of myositis that have necrosis. It can include toxic or drug-induced necrotizing myopathies. But when you're seeing these grouped regenerating fibers, that's when you want to be thinking about, could this be a muscular dystrophy? Okay. So that's general dystrophic pathology. And now we're going to focus on some of the specifics. So first we'll talk about dystrophinopathies. So dystrophinopathies are the most common form of muscular dystrophy. This is the beloved dystrophin glycoprotein complex. So this is, we call it the DGC, and it is a structural complex. And many of the proteins in this are integral, they are integral for the structure, maintaining the structure of the myofiber, but they can have genetic alterations in their genes, and that can cause different forms of muscular dystrophy. So here is dystrophin right here. It is actually connected to the actin cytoskeleton, and then through beta-dystroglycan and alpha-dystroglycan and myrisin connects up to the basal lamina. So this is connecting the inside of the cell to the outside of the cell. So the two prototypical muscular dystrophies are going to be Duchenne and Becker. The DMD gene is the gene that encodes the dystrophin protein, and alterations in this gene cause X-linked recessive DMD and BMD. So Duchenne is by itself the most common and prototypical, whereas Becker is a milder allelic variant of DMD. In Duchenne muscular dystrophy, the translational reading frame is lost. So any molecular alteration you're seeing in Duchenne muscular dystrophy is going to lead to a lack of protein that's being made. So in essence, you should see no dystrophin protein expressed. There are stars here because there are some exceptions, and you'll see another example of that. Whereas in Becker muscular dystrophy, that translational reading frame is actually maintained. The molecular alteration is such that there still will be some protein that's produced. It is not going to be full-length protein. It will be missing some key exons, but it's enough that it can be made and put in the right place and function a little bit. It doesn't function as well, but it does function. So Duchenne boys lose the ability to ambulate independently about the age of 14. This has been a little bit of a moving target, but I think that's the current understanding is around the age of 14 is more commonly going to be a Duchenne muscular dystrophy. And when you're dealing with patients who maintain independent ambulation longer, that's more likely to be a Becker muscular dystrophy. However, there is a continuum. This is not a black and white, it's either Duchenne or Becker. There can be some overlap. In both cases, your CK is going to be elevated 10 to 50 times normal, and the muscle weakness pattern is a proximal pattern in a limb girdle type form. So this is that continuum. The clinical presentation and your ability to ambulate is directly related to the amount of functional dystrophin. So the more dystrophin that you have that's functioning, the more Becker-like you are going to be and maintain the ability to ambulate longer, whereas more severe forms like DMD, you have less. And then there's this really intermediate phase where it's not really clear whether a patient fits better into the Duchenne or Becker camp. And that is where some of our biopsies actually are derived from. So when are muscle biopsies done for the diagnosis of DMD, BMD? Well, this is a good question because about 95% of the cases are actually diagnosed by genetic testing as of a paper from 2003. So, if 95% of them are done by genetic testing, what are we needed for? Well, it turns out we are. So sometimes genetic testing isn't actually diagnostic. If someone's only doing deletion duplication testing and not sequencing, they are not going to pick up sequence alterations that could be disease causing. This is less and less common as a lot of the genetic testing companies are now offering deletion duplication and sequencing as a package. That didn't used to be the case, but now that's more common. So that's less and less. But we are seeing now more variants of uncertain significance in the DMD gene. So these variants that a molecular pathologist isn't going to know whether it is truly pathogenic or not. And then that could result in some diagnostic confusion, and a muscle biopsy can help. Sometimes DMD or BMD isn't actually suspected clinically. This is coming about more in patients who are older at the time of presentation. You know, we've seen patients in their 70s and 80s who are getting diagnosed with dystrophinopathy. And you know, if you're a clinician and you're seeing a patient that is in their 70s or 80s with proximal muscle weakness, a dystrophinopathy is not the first thing you're going to be thinking of. And then also we do see manifesting female carriers. So despite having two X chromosomes and only one of which has an abnormal DMD gene, sometimes X inactivation can result in female carriers having proximal weakness and increased CK. And then sometimes the clinical presentation doesn't actually line up with the suggested molecular changes. So this is what I was referring to before, where the molecular alteration may suggest a very severe phenotype, but the patient's doing better. And the family would really like to know what to expect. It really helps understand prognosis and what kinds of supportive care is needed and how quickly it's needed to have an idea about how much dystrophin is actually being made in the muscle fibers. So sometimes clinicians will just order a muscle biopsy to help understand that. So what does DMD look like under the microscope? So this is going to be your very, very classic Duchenne patient. They are going to have a lot of myofiber size variation, hypertrophic, atrophic fibers, fatty replacement, endomesial fibrosis that you can see throughout here. Regeneration, and some acute necrosis. So dystrophic pathology. When you do immunostaining for multiple regions of the dystrophin protein, we have antibodies against the C terminus, 2 rod domain antibodies, and an antibody near the amino terminus. You can see controls are at the top and our patients are at the bottom. And our patient's biopsy really shows very little dystrophin expression in the majority of myofibers. So really almost entirely negative for all of these antibodies, with the exception of myofiber A. So why is myofiber A positive? Well, this is actually called a revertant fiber, and it is a classic finding in DMD when you have almost entire loss of dystrophin protein expression, but then there'll be 1 or 2 or 3 or 4 fibers that really strongly express dystrophin using multiple antibodies. And this is a phenomenon that is thought to be related to satellite cells and regeneration, although I don't think it's been fully elucidated, but revertant fibers are characteristic in DMD. You might be asking me, well, Karra, how do you know that this even worked? Like, what if the muscle biopsy showed proteolysis? What if there's no membrane protein? So it is really helpful always to add in an immunostain that is a membrane protein to confirm that, yes, there is preservation of those membrane proteins. So we like spectrin. Spectrin is a really good marker of membrane integrity. So yes, in fact, the myofibers are here, they're just not staining for dystrophin. Other helpful things that you can do, you can stain for utrophin. So utrophin is a homolog to dystrophin, and it is only seen in the neonatal period and the fetal period. And then it actually, the muscle starts producing dystrophin. And as it produces dystrophin, it stops expressing our RNA for utrophin, and it just stops making it. And so it's just not as effective as a structural protein as dystrophin is. So there's no need to have it once you start making dystrophin. But if you lose dystrophin, then utrophin gets upregulated. And so this upregulation of utrophin can be a helpful finding in dystrophinopathies. Now, I will say utrophin can also be upregulated in regenerating muscle fibers for other reasons. And so don't use that as, if you see utrophin, it doesn't completely equal a dystrophinopathy. You also have to have the loss of dystrophin. And then another helpful thing that you can do is nNOS staining. So nNOS actually binds to the dystrophin protein in the rod domain. And when nNOS is trying to bind and there's no functional dystrophin there, there's no dystrophin to bind to, then it ends up getting degraded. And so it has nowhere to go. So nNOS loss is also characteristic of a dystrophinopathy. So, I showed you some immunostains there, which are a little bit unique. It's not really what is out there in the community, what most people are using. this is the dystrophin protein here, the carboxy terminus, the amino terminus. And the most common antibodies that are being used for diagnosing dystrophinopathies are DIS1, DIS2, and DIS3. And this is where they're located along the protein, where they actually bind to the protein. And the issue is that if you're diagnosing a DMD case, you should be fine, because there should be almost total loss or a very significant loss of all of these antibodies with a DMD case. However, if you're dealing with Becker muscular dystrophy, the most common location to have alterations in the Becker cases is actually right here. And so if you don't add antibodies like exons 46 and exons 50 that cover this region, you are potentially missing a significant number of Becker muscular dystrophy cases. So just keeping that in mind, that it can be a pitfall when DIS1, DIS2, and DIS3 are staining normally, it may not be enough. So here's an example. Here's a case of a 55-year-old man who had some neck flexion and extension weakness and cardiac arrhythmias that began in his early 40s. They thought maybe he had myotonic dystrophy, which is the second most common muscular dystrophy in adults. A cardiomyopathy panel actually identified a VUS in the DMD gene. So he had this testing in his early 40s. And at that time, this variant was called a variant of uncertain significance. By the time he had his muscle biopsy in his mid 50s, the genetic testing company actually had decided, oh, this is actually now a benign variant. It's not significant. So everyone was really discounting that DMD variant. And then he had whole exome sequencing, which showed variants in other genes that cause a variety of different neuromuscular diseases in SYN1 and the TTN gene encoding Titin. So this is the muscle biopsy that was done to try to help sort out what was going on. And what you can see is there's fiber size variation, but this is not an overtly dystrophic biopsy by any means. DIS1, DIS2, and DIS3 were performed. And what you can see is that they have normal sarcolemmal positivity. These are really not lost, not concerning at all that this could be a dystrophinopathy. But keeping in mind that DIS1, DIS2, and DIS3, where they're located, are going to be at the far carboxy terminus, close-ish to the amino terminus, and then around exons 26 to 30. So when you go and you actually check where this patient's variant lies, this is a wonderful website, actually, this Dove website, which you can type in any DMD variant, and it will tell you a lot of information about it. It'll tell you what exon it's located at, and then if there are any known diseases that are associated with it, if there's in silico predictions, what those predict, and any kind of information about splicing. So it turns out that this variant is actually located in exon 49. And if we go back and look, we're not covering exon 49 with DIS1, DIS2, and DIS3. And there is a suggestion, it is definitely not definitive, it's not definitely been described in anyone with a DMD or BMD, but there's a suggestion that this variant could disrupt the exon splice enhancer and perhaps create even a novel exon splice silencer. So affecting splicing could be something significant. And we've seen this in patients with DMD and BMD before. So when we use an expanded panel on this patient's tissue now, what you can see is the C terminus, the carboxy terminus is normal, which goes along with what DIS2 showed. However, when we add antibodies to exon 50 and 48 to 50, there's total loss of expression. You're seeing a little bit of punctate positivity, but I'll show you what that is in a moment. And if you look at exon 47 just after it, it's totally fine again. So this punctate positivity is actually autofluorescence. So if you're doing immunofluorescence, keep in mind, if you're dealing with older patients, you're going to have lipofuscin, which is autofluorescent, and will show up in both the and any of the fluorescent cubes that you have. It'll show up with any of them. So that is actually not true dystrophin positivity. And when we do even further expanded panel, what you'll see is really the only region that is affected is right here. So our antibody that would be close-ish to DIS1, DIS2, and DIS3, they look normal. And our our missense mutation, we know it's in the patient, is actually located in this region where we have a loss of protein expression, suggesting that really they should further look into that DMD variant in this patient. So as a take home, dystrophinopathies are very common. You will see unexpected dystrophinopathy biopsies despite the advances in genetic testing. So keep them in mind. This can include older patients and female manifesting carriers. And classic DMD is characterized by a total loss of dystrophin expression with revertant fibers, utrophin expression, and NOS loss. And while DIS1 and DIS2 and DIS3 are good screening antibodies, they're not going to get you everything you need to diagnose dystrophinopathies. You'll miss a high percentage of BMD cases. So if your suspicion is high, you can either do the additional stains or send to a place that has the additional stains, or at least suggest it to the clinicians that it's not completely ruled out. Okay. Next, we're going to talk about Dystroglycanopathies, which we have a fondness for here with our Wellstone Center. And Dystroglycanopathies are also identified in the dystrophin glycoprotein complex. And they are related to alterations in alpha-dystroglycan, specifically the glycosylation of alpha-dystroglycan. So this is where alpha-dystroglycan sits. It is connected to myrisin, and again, it has an integral part in this, the structural integrity of the DGC and myofibers. And so as I mentioned, the important thing about dystroglycanopathies is actually the glycosylation of alpha-dystroglycan. It's a little bit unique in that because in the majority of other muscular dystrophies, it's a simple gene that's altered and the protein is altered, and therefore you have disease. For dystroglycanopathies, it's actually the glycosylation of that protein. So most of the dystroglycanopathies, the DAG1 gene is totally normal, but it's the glycosylation, the processing of that protein afterwards that's going to be altered. So dystroglycan requires a lot of sugar groups being added to it to function and bind. So here's alpha-dystroglycan here, and you can see that all of these genes that are listed in blue are different genes that are required to keep adding on sugar groups until you get, till you get to matriglycan here, that is where laminin binds, or myrisin. And that binding is really important for the structural integrity. So all of these proteins, that's taken many, many years to sort out, and I think there still are more that we haven't discovered yet that we're still working on. Everyone's still working on, you know, proteins from the ER, proteins from the Golgi, even ER trafficking and Golgi trafficking genes were recently described, but ultimately just knowing that it's altered glycosylation is the problem. FKRP is the most common dystroglycanopathy when there's mutations or alterations in FKRP, but there's significant phenotypic variability, which means that there's also significant pathologic variability. So we have everything ranging from Walker-Warburg syndrome, which you saw some beautiful images of the brains in Walker-Warburg syndrome before, all the way up to a more slowly progressive, less severe limb girdle muscular dystrophy with patients presenting when they're older. And this is by far and away the most common mutation in FKRP that can cause a limb girdle muscular dystrophy. So what do these look like? Well, this is a 26-year-old man who had a 6-year history of progressive proximal muscle weakness. CK was greater than 5,000, and DMD deletion duplication testing and sequencing was normal. So it makes sense that they would be doing this. It's a man with a very high CK. This is the muscle biopsy that was done. And what you see is there are some regenerating fibers, and they're somewhat grouped here. There's some fiber size variation, not overtly severe and chronic, maybe a little bit of endomysial fibrosis, but still suggests a dystrophic pathology. And when you do immunostaining for glycosylated alpha-dystroglycan, we use the 2H6 antibody in this preparation, but glycosylated alpha-dystroglycan actually shows abnormalities. And this is very subtle, but it is here. So the nice thing about immunofluorescence is that you can actually set your exposure to the control on the same slide, and then you can look at your tissue and see the difference. And what you see is that almost every myofiber actually is fainter than the control. And not only that, but there are myofibers in here that are entirely negative. So dystroglycanopathies can actually be very, very patchy and show very subtle changes like this one. particularly the common and less severe dystrophinopathies. And beta dystroglycan, in contrast, is intact. So beta dystroglycan is not usually going to be lost in these dystrophinopathies. Genetic testing in this patient did reveal actually the common mutation in FKRP. But the key to dystrophinopathies is to know that there is a lot of phenotypic variability. So I'll show you a variety of cases. So this is a patient with FKRP mutation that had more of a congenital muscular dystrophy phenotype. And what you see is there's really no 2H6 positivity here. Here's the DAPI to prove to you that there are actually muscle fibers that are present, but very, very little 2H6 at all. Another patient with a slightly less severe look of 2H6. And so what you can see is that there is some 2H6 still here, but much less. It gets even less severe here. And then this patient with a GMPPB alteration with an LGMD phenotype may be really even tough to decide if that is actually truly lost or not. When you compare it to the control, it does appear to be, and there are some myofibers that are negative, but it's very patchy and not very severe. So a patient like this, it can be really helpful to do additional testing. We can actually do Western blotting, which I'll show you in a moment. And it is also helpful to keep in mind that glycosylated alpha-dystroglycan is present in the peripheral nerve. So alpha-dystroglycan is located on Schwann cells. It's a receptor on Schwann cells. It's actually, interestingly, they think it's the receptor for Mycobacterium leprae, how it gets into the Schwann cell. And so if you've got a patient with a dystrophinopathy, you may actually see a nice internal control with your peripheral nerve, but the muscle fibers themselves can be negative. So as I talked about the Western blot, this can be really helpful in the more less severe cases, in the cases that are really hard to know if there really is truly loss or not. And here you can see this is where control alpha-dystroglycan sits. This is the actual peptide of alpha-dystroglycan. And as you would expect, if there's a problem with glycosylation, the molecular weight will be less. And so here are different various patients with all different mutations in the FKRP gene. And you can see that this molecular weight is significantly lower than the control tissue. And that's because of this altered glycosylation pattern. And then if you do a 2H6 antibody, the glycosylated antibody, in this case, they were entirely negative. So Dystrophinopathies have widely variable clinical and pathologic findings ranging from very mild to very severe, even within the same gene. That's what always fascinates me. The pathophysiology involves this abnormal glycosylation of alpha-dystroglycan. So you really need to be looking at glycosylation specific antibodies. If you've got just an alpha-dystroglycan peptide antibody, that is not going to help you out with your diagnosis because most of the time it's going to be entirely normal. And you would expect also that beta-dystroglycan should be mostly, if not entirely, normal. And Western blotting can really help in cases that are difficult to interpret. All right, we'll move on to Dysferlinopathies. I wanted to talk about Dysferlinopathies because they have some unique features. So we're moving beyond the dystrophin glycoprotein complex here. We're moving on to over here to where dysferlin is. Dysferlin is not actually a structural protein like the others we've talked about so far. Dysferlin is actually a protein that's involved in membrane repair. So it sits within the sarcolemma and it has this function of being associated with repair vesicles. You can see down here. And so if the plasma membrane, the sarcolemma gets disrupted, then actually dysferlin goes and fuses up and patches the membrane itself. So it's very important for membrane repair. It can also have a variable clinical phenotype. So you can have patients with proximal muscle weakness and more of an LGMD phenotype, or you can have patients with distal weakness and more of a Miyoshi myopathy phenotype. And it has a few unique histopathologic findings that I think will be helpful to you as you look at muscle biopsies that you don't necessarily need, really fancy immunostains for. So This is what a classic dysferlinopathy biopsy looks like. And again, our dystrophic pathology is very clear here. Hamlet is the name of the antibody that we usually use for dysferlin. It is exon 53 of dysferlin. And I love this because I love Shakespeare and Shakespearean theater. But if you look back to what dysferlinopathies, the name of it used to be LGMD2B. And so very cleverly, this was named Hamlet because a famous quote from Hamlet is "to be or not to be." So this is the patient's Hamlet antibody. This is the control antibody. And what you expect to see in dysferlinopathies is that it'll be entirely negative. You are not going to expect to see really any positivity. It's not patchy like the Dystrodglycanopathies or patchy like BMD. It's just going to be negative. One pitfall that we see very frequently is that there can be actually a loss of the sarcolemmal positivity and an increase in cytoplasmic or sarcoplasmic positivity. So if you see that pattern, know that that is nonspecific and it is not diagnostic of a dysferlinopathy. And so this kind of punctate positivity is probably related to membrane repair. We see it a lot in different myopathies, other muscular dystrophies. You can see it in myositis cases. So it is not a diagnostic of a dysferlinopathy. It can aggregate in cores and targets. So that's kind of an interesting phenomenon as well. And you can also do Western blotting for dysferlin. Here you can see this is the control tissue at varying concentrations and at a similar concentration to 1x and 2x here, you can see dysferlin is entirely negative in this patient, while calpain is maintained. We usually do our dysferlin with calpain on our Western blot there. And so, there was a lot of buzz about dysferlinopathies and inflammation. So this was one of the things that people have been touting as a unique feature of dysferlinopathies, that they have either perivascular or endomesial inflammation very commonly, so much so that you could confuse it for a case of myositis. And so that's been, the dogma that's been kind of proliferated over and over again. But it really wasn't the experience here. It wasn't what Steve had been seeing, and then later I had been seeing too here in Iowa, that the inflammation really wasn't that severe. We see inflammation fairly commonly in other muscular dystrophies. So we've systematically now looked at these biopsies with this project's being led by our wonderful resident Nicole Becker, who's going to be doing her fellowship at Michigan. We're really excited for her neuropath fellowship. But we took dysferlinopathy biopsies, Becker biopsies, calpainopathy biopsies, and compared those to dermatomyositis spectrum and IBM cases. And we stained them for different inflammatory markers. This is just showing you the T cell markers. And we also did B cell markers and macrophage markers, and did a whole slide scanning and then image analysis to identify how many inflammatory cells in each subset were there. And what you see is actually the dysferlinopathy biopsies are really similar to the Becker muscular dystrophy biopsies, the calpainopathy biopsies. So this does not suggest that there is more inflammation. And this was the same for all of the inflammatory markers. There's really not more inflammation than other muscular dystrophies, other comparable muscular dystrophies, whereas there significantly is more in the myositis cases. But what is very helpful and very significant is that dysferlinopathies really do have complement deposition, more so than their counterparts. And so this is complement C5b9, and you can see a dysferlinopathy biopsy. It's myofiber positivity that is really, really significant in dysferlinopathy biopsies. You can see that almost every single biopsy at least had focal, many had diffuse myofiber positivity for complement. And that is significantly different than what we're seeing in our Becker and calpainopathy cases, and fairly similar to what we're seeing with dermatomyositis and IBM. And this is an IBM case here that you can see also the myofiber positivity more in a punctate sarcolemmal pattern. And it almost is even more broad-based in the dysferlinopathy cases. This has been published before that there's complement there, but it was really nice to actually be able to compare these cases and see that there really is a difference. The other thing that is unique that you can identify in these dysferlinopathy biopsies is amyloid. And so if you ever get a biopsy with a muscular dystrophy, you can do an Congo red stain looking for amyloid to help point you in that direction that it could be dysferlinopathy. The amyloid actually deposits in vessels. So you can see here in vessels. It also in the endomysial space, you can see that there'll be some amyloid in the endomysial space, and then also in the subsarcolemmal space in myofibers too. So just look for amyloid to give you a clue that it could actually be a dysferlinopathy. It's not completely unique because actually there's some overlap with anoctaminopathies and laminopathies. So ANO5 can actually also show amyloid deposition. You can see this is a report here showing amyloid depositing in a case of ANO5. And then also, just from our experience here, ANO5 and LMNA disease can also show complement deposition among myofibers. This hasn't been published yet, but this is what we have seen. These are very, very rare muscular dystrophies, so there aren't a lot of cases out there, but the cases that we have seen tend to have complement along with the dysferlinopathy biopsies. So proximal or distal phenotypes for dysferlinopathies. You get total loss of dystrophin expression to be diagnostic of disease, and don't fall for the pitfall of that nonspecific sarcoplasmic positivity. While inflammation can be seen, it's actually at a level that's really comparable to other muscular dystrophies and less than you would expect in myositis. But complement deposition is a helpful feature and shared with ANO5 and LMNA, and amyloid deposition is also a helpful feature. It's not seen in every case by any means, but if you do see it, it's helpful. Okay, and then we'll switch over now to, let me do a new share to our path presenter. So I only shared the, let's see here. Oops, sorry. Oops, I shared the wrong one. Here we go. So I only shared with you all the actual H&E, but we've got some other things that we can look at now. So what you can see in this muscle biopsy, and I hope you all picked up on it, is that it is a dystrophic muscle, as you could guess. We have some areas with some acute necrosis right here. And we have areas that have regenerating fibers. That's a single regenerating fiber, but there's also grouped regeneration. If we come over here, you can see some areas of grouped regeneration over here. And there's also a little bit of inflammation, just out of interest. Maybe some of you saw, there was some inflammation that didn't really seem to be associated with necrotic fibers. Okay, so we now know this is looking like it's a dystrophy, at least it's very high on our differential. And it turns out this was a 72-year-old man. He had a multi-year history of gradually progressive proximal muscle weakness. Interestingly, his CK was elevated while on a statin, so he was taken off of it, but his CK remained elevated at greater than 10,000. So this clinical presentation would make me definitely think about an immune-mediated necrotizing myopathy. Maybe this patient has anti-HMG-CR antibodies, like Dr. Margetta talked about, and the CK is still high because it's now become an autoimmune process. He's 72 years old, that would make a lot of sense. However, if we do immunostaining in this muscle biopsy, we can start with DIS1, DIS2, and DIS3 equivalents. These are the equivalents that I had here. And so you can see that DIS1, DIS2, and DIS3, you might do those stains and just, okay, let it go. I'm done. It's not a dystrophinopathy. It's probably immune-mediated necrotizing myopathy. But if you expand out your panel and include those areas in the rod domain that are fairly commonly seen in Becker muscular dystrophies, what we actually saw is there was a significant drop-off in exons 46 through 50 of the dystrophin staining. And so this was really concerning for, this could actually be a patient in his 70s who's presenting for the first time with a Becker muscular dystrophy. We went back to the clinicians, let them know, they ordered genetic testing. And it turns out that actually this patient has an in-frame deletion, a deletion between exons 45 and 48. If you do this, I love this website too, the Lovid deletion duplication frame checker, it'll tell you if a deletion or a duplication in DMD is going to suggest in-frame or an out-of-frame alteration. And this is an in-frame deletion, which makes sense with our immunostaining pattern that we have. And the patient was diagnosed with Becker. And you may say, well, he's in his 70s, he's doing fine. What does it matter? Well, this has really strong implications for his family, for him to know for his prognosis moving forward. He doesn't need to be on a lot of immune modulators. And so this was a really positive thing that we were able to help make that diagnosis and get the patient to a point where that they knew what was going on. So that was that case. And now I am available to take any questions. Sorry, I hope timing was okay.
Yeah, no, that's fine. So at this time, we'll move into Q&A. You may submit your questions via the chat box or unmute to ask a question. When submitting a question via the chat box, please ensure the message is to everyone so that we can all see it. And to unmute, select the microphone in the lower left corner. And once you've asked your question, please remute to avoid background noise.
Okay, so I do see one question. Do you ever see MHC1 and or MHC2 expression in dystrophic muscles? Yeah, so absolutely. We don't usually do MHC class 2 staining here, but MHC class 1, we actually do in every suspected muscular dystrophy biopsy. And the necrotic fibers often show expression of MHC class 1 along them. It is usually in a somewhat of a patchy distribution because it's really mostly associated with the necrotic fibers. It's not usually the pattern to see diffuse MHC expression like you would expect in a myositis case.
So this is Angelica. I'm not sure if I missed this, but for the utrophin expression, when does it normally stop, and when would a Duchenne's patient, do they have it like immediately upon birth? Like, what's the difference between normal?
Yeah. So usually at birth, most of the utrophin expression has stopped. Dystrophin starts at late in the fetal period, and then in the early neonatal period. And so most of the patients with dystrophinopathies with Duchenne muscular dystrophy they don't present immediately. I mean, it can be a really severe form, but most of them are going to be presenting when they're a little bit older. And so we wouldn't expect them to have any utrophin expression at that time. But as I was saying, regenerating fibers in general can also express it. So, utrophin expression does not equal a dystrophinopathy.
Okay, thanks.
Oh, yeah. So Dimitri's asking about C3D deposition in Dysferlinopathies. I have never done it. I don't know. I'm trying to think about the papers that I've read. I don't think that I've actually seen anyone doing that specifically, but I can look. I can look and find out. I don't know for sure. And Manuel's asking, how sensitive is nNOS IHC for deletions in the corresponding rod domain of dystrophin? So if you have a really robust nNOS antibody, it doesn't always suggest that there's only loss in the rod domain. So obviously, if you have a Becker case and there's loss in that region, you would see loss of nNOS along with loss of proteins or antibodies that hit those exons, that region. But you can also see loss of nNOS in Duchenne cases where the alteration could be anywhere else in the protein, but it is an out of frame alteration that results in no functional dystrophin at all. So it can be seen in both Becker and in Duchenne cases, depending on just the severity of the alteration and where it's located. And then Greg is asking, how does a revertant fiber originate genetically in DMD? How can dystrophin expression be restored in a myocyte without the genetic coding for the protein in the myocyte nuclei? This is an area of a lot of research because, you can imagine that people are trying to study and try to cure dystrophinopathies. And so they're like, okay, if you can actually have expression of dystrophin in some myofibers in this, how can we use that to treat the patient? And so I think that my understanding is there's still a lot unknown. It is thought to be related to satellite cells and regeneration. And it's not totally clear to me how that happens, but that is my understanding of it, that somehow during regeneration and satellite cell proliferation there is some way that there is some dystrophin that's expressed. It's probably not full-length dystrophin. I don't think anyone ever thinks it's actually the full-length and fully functional dystrophin, but there's enough of it that's there that we can pick it up with our antibodies. Would you please show the summary slide for Dysferlinopathy again? Happy to.
Karra, do you mean in the second line, the total loss of dysferlin expression? I think, is that, you have total loss of dystrophin.
Oh, my goodness gracious, yes. Thank you.
Question I have, yes.
Thank you, I am so sorry. Yes, dysferlin expression, so sorry. Okay, and Marie asked, what features made you decide to test for dystrophin proteins in the last case? The clinical presentation is so good for IMNM. So we actually very often will do muscular dystrophy staining in cases that are concerning for IMNM that don't quite fit. So you could start by doing, MHC and complement and see if the pattern really is consistent with immune-mediated necrotizing myopathy if you wanted. And then if it doesn't fit that, then you could go and do dystrophinopathy testing. But yeah, we're fairly liberal with our muscular dystrophy stains here, just because of the experience that we have where we're picking up things that are otherwise not really suspected. And from Dr. Lopez, for the majority of practicing neuropathologists, commercial dystrophin antibodies do not cover the less common exon alterations. How do you recommend to overcome this problem? Yes, so absolutely. I mean, I think that starting with DIS1, DIS2, and DIS3 is good if that's what you have available. Actually, the antibodies we have are available to purchase if you wanted to work up at least a couple of antibodies within the rod domain. They are not proprietary. They're not just our antibodies. So you could absolutely bring up an exon 46 and exon 50 antibody in your lab and be doing those regularly. But yeah, I think the key is to know that it is a pitfall and not completely exclude dystrophinopathy just because DIS1, DIS2, and DIS3 are positive and normal. If that makes sense. And you're very welcome to send cases to us too.
All right, thank you everyone again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation, which was just entered into the chat box. Completion helps to ensure accurate reporting to the accreditation board. It may not display as a link, so please copy and paste it into your web browser if needed. And the PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Jones for an excellent presentation, and this concludes the session for today.
Thank you all.
Thank you.